All right, everyone, I think I'm just going to get started, okay, and is everyone coming in? So my name is Christina Awad. I'm just going to go through viral hepatitis today. All right, so the biggest portion of my talk is going to cover viral hepatitis B. We're going to talk about chronic, acute. It's probably one of the more complicated viruses out there. I would tell you that if you're ever going to give a talk and you're between Hep B and Hep C, you should just do Hep C and have someone else do the Hep B talk, just because it's super complicated. There's a lot of changes. I tried to keep it up to date. So we'll go from there. And then hepatitis C, again, a lot to cover. Tried to keep it simple. And then hepatitis E, and then we'll end up with hepatitis A. So just a picture there of hepatitis B. One of the big things I want to highlight for you is the E antigen that's right there in the green. You can probably see it. It's on your right-hand side. So it's a pre-core gene, so it's really important, and it's actually the target of the immune response to inactivate hepatitis B. And it will become really important in talking about therapies and talking about what is hepatitis E antigen positive versus E antigen negative. So that's kind of really important. And sometimes there's a mutation in the E antigen, and that's the most common mutation actually. It's found in hepatitis B patients. And patients that have that mutation can't really respond to therapy, so they end up unfortunately being on therapy for a long time because they cannot seroconvert, and we'll go through that. So basic hepatitis B is a partially double-stranded virus. It has so many different genotypes, A through J. Chronic infection, the patient have to have a surface antigen for at least 6 months in order to be considered chronic. Now, it's there's a lot of variation between countries, and we are, multicultural country. We have people coming from all over the world, so we have to be kind of educated on who are our high-risk patients and where is this virus endemic to. It's also can be transmitted prenatally, and it's actually the most important cause of chronic infections. So a lot of your patients today that have chronic Hep B unfortunately got it during birth or prenatally from their mom. It can also come of sexual exposure, close person-to-person contact. So the highest prevalence of hepatitis B, chronic Hep B, would be in China and Mongolia. Unfortunately, it's also in Asia and East Europe and Sub-Saharan Africa and the Caribbean islands. And you got to remember that in the United States, immigrants from these countries account for about 50% of all chronic infections. African Americans have the highest prevalence of hepatitis B in the United States. All right, so who do we screen, right? There's everybody, right? These are the guidelines, right? Everybody that's not vaccinated, everyone that was, people who, inject drugs, people who are immunosuppressive therapy, if you have elevated ALT or AST, donors, all pregnant women, patients with HIV, just so many indications. So basically, I would say almost everyone, you gotta test them for hepatitis B, right? If you've ever been pregnant, you gotta test it for Hep B. All right, so now you want to test the patients, and then you get the results. What does it mean? So you have to so what exactly, when you get the panel, what's the panel looking for? Well, the biggest thing is you want to look is the surface antigen. Is it positive? Is the surface antigen positive? So the way I think about it is the antigen is what tells you the patient have the virus, right? So if that's positive, then there's something there. If they have the core antibody is positive, then that means maybe they had a prior exposure. If the antibody is positive, surface antibody is positive, then you're thinking, okay, maybe they got the vaccines. That's different, right? So whenever you want to confirm an infection, you have to have the surface antigen, and then plus or minus with the DNA of the virus is elevated. You do want to screen in for hepatitis D because they travel together in some ways. And then when you are concerned about an acute infection, the IgM core antibody and the surface antibody is positive. When you have somebody with acute, the ALT and AST are in the 1,000. They're so high. Chronic is not necessarily. And unlike Hep C infection, acute Hep B, is more commonly associated with more signs and symptoms of hepatitis. All right, so you got your labs, it came back. All right, what does that mean, right? It's like, oh my goodness, what does that mean? So let's say you got your labs back for your patient, the surface antigen is negative, but the core antibody is positive, and the surface antibody is positive. What does that mean? Are they actively infected? Right, so they're immune due to natural infection. Why do I know that? Because the core is positive. It's not the surface antibody, it's the core antibody is positive. Gotta remember that. All right, so you got your labs back and the surface antibody is positive. Are they infected? No, they just had the vaccine. All right, you got your labs back and only the IgM is positive. So that's actually the window period there. Because once you get the acute infection, there's a window period where the surface antigen starts to clear, and that is the window period. So what about if you have the surface antigen positive, the core antibody is positive, the IgM is positive? What is that? Acute infection, that's right. And then last but not least, they have the surface antigen is positive, the core antibody is positive. That is your chronically infected patient. Now, there's a lot of changes recently with names and things, so I'm going to highlight to you where the names have changed so you know what the old names are, because if you're working with people who haven't adopted the new names, you're familiar with both, I guess. So the top there is what we call immunotolerant. Now that is no longer a thing because people get confused by immunotolerant. What the heck does that mean? It's now called the Hep E antigen positive chronic infection. And from the name, right, you have positive E antigen, your DNA is high, but guess what? Even though the DNA is high, the LFTs are normal. There's, the body's doing their thing. They usually either a patient that got it at birth or they're really young and they're used to having the virus. Does that mean we should track them and make sure they don't get sick? Yes. You don't just be like, oh, bye, I'll see you, never. No, these are patients you got to monitor, okay? So what happens if the patients have E antigen positive, the DNA is high and the ALT is high? These are the patients you have to monitor because they can get progressive liver disease. These are the patients you want to make sure you're screening for HCC. You want to make sure, is that somebody I need to treat or not, okay? So that's the first 1, 2 there. And then at the bottom is what used to be called inactive carrier. Now that kind of misled a lot of people. They're like, oh, they're inactive. What's that mean? So the other name for it is Hep E antigen negative chronic infection. So like I told you in prior slide, the E antigen, they have that mutation, okay? The DNA is low. They have normal ALT, so those are patients we kind of monitor, right, to make sure they don't, have an elevated DNA and then the abnormal ALT. And then last but not least is the E antigen negative chronic Hep B, where the negative E antigen, the DNA is elevated and then abnormal ALT. And those patients can obviously progress into liver disease. All right, so again, remember that surface antigen has to be positive for at least 6 months in order for them to be called chronic. You can have normal ALT, you can have elevated. The DNA could be really high in the billions, or it could be even undetectable. These patients, when you do biopsies on them, they have variable, necroinflammatory or maybe even fibrosis. And then, like I said, it's subdivided into categories, and that's what makes Hep B really confusing if you don't do it a lot, is what stage is the patient in, which one do I need to treat. So we'll try to break that down today, because that's like really the most important thing. What am I supposed to do with these labs? What am I supposed to do with this data? Is this patient needs to be treated? Do I need to follow them? Do I need to screen them for HCC? What do I do with this data? The biggest break is the DNA level. So typically, if they're E antigen positive, your key for the DNA is 20,000. That's where you can start to get concerned, like, I should probably treat this patient. The biggest, whenever they're E antigen, typically they're lower, the DNA level is lower, usually 2,000 to maybe 20,000. All right. So again, immune tolerant, usually very, very tolerated by the patient. They usually seems like it doesn't really have any effect on the patient. The majority of patients, like I said, are Asian. They usually had the disease very, very long time, very young age they acquired it. Doesn't typically progress. However, you should monitor them, make sure they do not turn into fibrosis. Again, the DNA, whenever the DNA is greater than 2,000 or they start to have elevated ALT, that's when you should consider treatment. Now, inactive, those patients, usually DNA is low, they usually have persistent normal ALT, AST, the E antigen is negative. You should not be treated, but you should definitely consider treatment if you have fibrosis or the ALT becomes elevated. All right, this is kind of to summarize all the things that we talked about, what the levels would mean and which category that would be, okay? All right, so now there's which patient to treat. You have the gray zone, which patients we don't really know for sure, and then the patients that you don't need to treat. So whenever you have, this table is only E antigen positive patients. If you get an E antigen positive patient and the liver enzymes look fine, and your DNA, it might be a little bit elevated, you don't have to treat those patients, but you have to monitor their LFTs. That's the far right kind of a drop down. In the middle is the gray zone, okay? The middle is ALT is greater than the upper limit of normal, but it's not double the upper limit of normal. And then you have the DNAs greater than 20,000. So those are patients you have to look for causes. Why is the liver enzymes high? Do they have fibrosis? Is it MASLed? Is there another cause, like they have Wilson's disease or some other cause why the liver enzymes are high? And then on the far left there, if your patients have a DNA greater than 20,000 and the ALT is twice the upper limit of normal, those are the patients that you treat, okay? If the ALT is twice the upper limit of normal, but your DNA is only between 2,000 and 20,000, again, those are the patients that you want to monitor. And if it's persistently elevated, if the ALT is persistently elevated, then you could consider treating those patients. Any questions about that part? All right, we'll move on to the negative, E antigen negative. Again, the numbers here change, right? 2,000 is your key for the DNA level. For E antigen positive, the key DNA is 20,000. For the E antigen negative, it's 2,000 for your DNA. So again, if your ALT is fine, your DNA is less than 2,000, you don't have to treat those patients. But if the ALT is twice the upper limit of normal and your DNA is greater than 2,000, you should treat those patients. Everything in between, a lot of monitoring, a lot of looking for other causes why the liver enzymes are elevated. All right, now, I don't want to confuse you, but I must tell you what the WHO came up with new guidelines and have not been adapted yet. For like the AASLD has not adapted them, but I do want you to know these things because I want you to have like the most updated data. So WHO said, well, okay, we don't want to focus more on like the stage of fibrosis more than, all these like E antigen positive, E antigen negative. They're like, this is super confusing. And as you know, hepatitis B is a worldwide disease. It's not just the United States. So they want to make sure they treat more people, okay? So they said, all right, we're going to treat anybody with stage fibrosis at an F2 or above. If the DNA is greater than 2,000, we don't care if you're E antigen positive, E antigen negative, we're going to treat you. We don't care. It used to be 20,000. They're like, we don't care. If your ALT is elevated and your DNA is greater than 2,000, you're going to get treated. And they want to make sure, like, if you have HIV and Hep B, you're going to get treated. If you have Hep C and Hep B, you're going to get treated. So it's just kind of like it's this whole new thing. So I want you to know these are not like the AASLD, but they are in the WHO. These are the new guidelines. And basically what I circled there is basically where the new guidelines is, right? If it's the DNA is greater than 2,000, the ALT is elevated, don't care if you're E antigen positive or negative, the WHO says you treat those patients, okay? All right. Again, this is, I basically copied that from the guidelines of the WHO, right? They're telling you, like, if they have fibrosis, the DNA is greater than 2,000, and the ALT is elevated, or if they have, co-infection, if there's a family history of cancer, if they're immunosuppressed, if they have other comorbidities. It's honestly, they're trying really hard to treat everybody, So that's basically kind of where it is. Treatment-wise, I'm not going to belabor that, but there's, entecavir, the TDF, and the TAF, and it's just like, as you know, there's just the TAF and the TDF, there's just a different formulation of kind of the same drug there. There's PEG interferon as well. I won't go through that because I feel like I have not really seen it been used. And there's another, like adenofir and telobenafir as well, but those are not used as, those three are like the working horse there. Special populations, compensated cirrhotics, you treat those patients regardless of their ALT because you want to try to prevent decompensation from happening. Again, tenofovir and entecavir are your preferred drugs. We don't really know how long is recommended, how long to treat them for. Usually I just treat them basically indefinitely. Decompensated cirrhotics, also, we don't really care what the DNA is or the E antigen status or your ALT, we're going to treat you. Pregnancy, remember that if the infant will have to receive Hep B immunoprophylaxis if the mother have hepatitis B, and if the DNA level is greater than 200,000 in the third trimester, the mother needs to be treated. You can certainly stop that at birth or at 3 months. Make sure you're always monitoring the mom, especially after birth, especially if you stop the treatment, to make sure that the ALT and AST are still doing okay and there's no flares. All right. HCC screening in those patients with cirrhosis, you have to screen those patients. If your patient have chronic hepatitis B and they're Asian or black men greater than 40, you must screen for HCC. If they're Asian greater than 50, they must treat them for HCC. They have a first-degree relative, HCC, with history of HCC, if they have hepatitis D, and if they're born in Africa and they're greater than 20, they need to be treated. Screened. And the screening is ultrasound plus AFP. And sometimes they don't if this means if they're not cirrhotic, you still screen them. Just because they have hepatitis B infection and they're Asian greater than 50, you must screen them. I actually had a patient who was born in, I think, somewhere in West Africa, and he presented to the hospital really ill and ended up having like advanced HCC. And it happened because he had hepatitis B that nobody ever checked him for it. And he told me that his mom died from some liver thing. And he was in his 40s, and it would have been, and when I look back on all his labs, his ALT was like mildly elevated for like almost 20 years. And that would have been a very treatable virus if we caught it 20 years ago, and now he went home on hospice to die from HCC. It was something that could have been treated. So you remember, high-risk patients, when you have a patient with chronic Hep B comes to see you, remember those patients with high-risk, the high-risk categories, you should be screening those patients for HCC, whether or not they have cirrhosis. Quick word about Hep B. The likelihood of someone having liver failure from an acute Hep B is less than 1%, and their progression to chronic liver disease is less than 5%. This is in adult patients. And when the younger you are, the more likely you will, progress into chronic Hep B. Remember, patients that are immunosuppressed, have Hep C, HIV, pre-existing liver disease is a different story. Whenever the patients that you should concern about for acute Hep B, if your patient starts to have like a longer phase of like this liver failure, you're like, what the heck is happening? Their INR is like greater than 1.5, or they have like the bilirubin is greater than 3 for at least like 3 to 4 weeks after the infection. These are the patients that you should treat them, and just be on the lookout, because their acute Hep B is starting to look like it might take them to liver failure, and they might need a transplant. All right. Those are all the whirlwind of Hep B. And then I'll talk about Hep C. Hep C and Hep B are no joke, right? This is a heat map there. Millions and millions of people all across the world have both of them. Hep B seems to be higher than Hep C, but nevertheless, it's all over the world. And I think that's why the WHO is trying to eliminate Hep B in particular, and that's why they're starting to kind of be more aggressive about treatment than we do in the States. All right, so Hep C, basically, every time you see a patient that's greater than the age of 18 and they've never been screened for Hep C, you screen them just one time. Obviously, if you do more periodic screening, if your patients have risk factors like injecting drugs, men who have HIV, and men who have sex with men. And the way you screen them is you get the Hep C antibody, and if that's positive, then you do a confirmatory test with the RNA. All right. I mean, okay, so you tested them, they're positive. What do I do? How do I assess this patient? Well, obviously, the first thing you want to make sure they're not cirrhotic. You want to get their FEP score, you want to get a fiber scan, some sort of a test to tell you that they're cirrhotic. You start to be concerned with cirrhosis if there is splenomegaly, if there's liver nodularity on imaging, and then if you look at their platelets and they're less than 150, or if you obviously have a liver biopsy that proves they're cirrhotic. Always make sure you look at their medications, because when you treat them, a lot of the medication have a lot of cross reactions with other medicine. It makes them intolerable, and I'll go through some of those kind of drug-drug interactions. Some labs you have to get once you beforehand. You want to check their CBC, make sure they're not anemic. You want to see what your LFTs, what kidney function are you dealing with. You want to make sure, do they have HIV also? Do they have hepatitis B? Because hepatitis B can flare and actually kill the patient if you don't treat the both of them at the same time. Is the patient pregnant? Are they gonna, do they have some sort of birth control? Because if you treat hepatitis C treatment, there's not really a lot of data on whether or not they're safe during pregnancy. So you must educate the patient on that. And then you want to see, are they on a diabetic medications? Are they taking warfarin? Because the INR can change based on the medications for hepatitis C. All right, once you treat them, there's the SVR, like how long, did they clear the DNA or the RNA within 12 weeks? And then you want to make sure you counsel the patients on avoiding alcohol use. When you look at the RNA for Hep C, basically our drugs target kind of like the middle and the end. So like NS3, NS4B, NS5B, and NS5A. Kind of like challenging to remember, but I try to give you the prefixes there maybe to help you remember that. So if the medication contains a Provir, then that targets protease. So Provir, protease. If the drug has a Puvir, then it's an NS5B polymerase. And if it's an NS, I think I have this. So you see how like protease inhibitor, so it ends with Previr. If it's an NS5A inhibitor, then that has a prefix Asavir, ASVIR. And if it has NS5B inhibitor, it would be Puvir, okay? And then the drawing kind of tells you where exactly it basically targets in the drugs. Okay, all right, we're gonna go through kind of the things to look out for here. So they tried to make it very simple. There's a simplified Hep C treatment. So this is a patient who's treatment naive and they don't have cirrhosis. So that's any patient with chronic Hep C and they do not have cirrhosis and have never been treated with for anything for hepatitis C. So those are not your patients that were treated before. These are not your cirrhotics. These are not your patients with HIV or hepatitis B. Those are not the patients with HCC. Those are not the patients that have been transplanted before. This is your naive patients, never been treated, not cirrhotic. So the first drug we'll talk about is Mavyret. So that is very well tolerated. You can treat it with any of the genotypes. Biggest adverse events is patients getting a headache, please do not use that drug in moderate to severe cirrhosis. Okay. Next one is epiclusa. The one thing I want to remind you is make sure you test the patient for Y93H, especially in patients who are cirrhotic with genotype 3. Do not use it with patients who are on amiodarone because it can cause them to have bradycardia. And avoid drug-reducing medications with epiclusa because it can actually denature the drug and makes it not tolerable. So avoid amiodarone, a big thing, and then avoid acid-reducing medications. All right, Harvoni is next. Remember, Harvoni is only for genotype 1, 4, 5, and 6. Harvoni is like pretty readily available. It's probably one of the cheaper ones, so that's the drug you kind of want to use. Use it for 12 weeks if in naive patients who are not cirrhotic and you have a very high SVR rate. Again, you do want to avoid the amiodarone with this drug just because it has the soposbuvir drug, because that can cause pretty deadly bradycardia. And again, try to avoid acid-reducing medications. All right, well, what about patients who are compensated cirrhotics and they're treatment naive? All right, so if your patients have genotype 1, 4, 5, or 6, you can use Harvoni if they're compensated again. If they have type 2, you could use either Mavyret or epiclusa. If they have type 3, you could use Mavyret. So this is basically all the types here, okay? So Harvoni is your go-to if it's 1, 4, 5, or 6. If it's a type 2, you can use Mavyret or epiclusa. If it's a type 3, you want to use Mavyret. All right, and this is kind of like, I put them all the durations because it's different whether or not they have cirrhosis in this table and how long you do it for. And then the last line is on Vasevi, which Vasevi is for patients who have been treated before with other drugs. You can try Vasevi for 12 weeks. All right. Now, then what do we do with patients who have decompensated cirrhosis and they can use ribavirin eligible? It's just kind of the same thing, right? You can, if they're genotype 1, 4, 5, or 6, you can give them, Harvoni, remember that. So these are kind of like the summary here. So Mavyret is ban-Tibic. You can give it in compensated cirrhotics. Epiclusa, again, ban-genotypic, so you can give them in all genotypes. Again, you can use them in compensated cirrhotics. Remember to test them for that Y93H genetic mutations, especially in cirrhotic patients, genotype 3. And then Vasevi, those are the patients who failed before. And then Harvoni, you could use it in 1, 4, 5, or 6. And then there is also Zepetir in only genotype 1 and 4. And then just remember that for RBV, which is ribavirin, you can use those patients you can use that in cirrhotics as well. All right. Any questions about Hep C? All right. Hepatitis E, real quick. So it's a small virus. It's single-stranded. It's basically endemic. There's 2 types, 1 and 2. 1 is endemic to Asia and some parts of Africa. 2 is basically restricted mainly to Africa. It only affects human. Basically, a lot of type 1 is waterborne, and then type 1 and 2 are waterborne, and type 3 and 4 are in animals. Let's see, anything? Okay. It has an incubation period about 40 days. A lot of it is like asymptomatic, but it can actually cause fulminant hepatitis in about 1% of patients. Type 3 can lead into chronic infection and can have, especially in patients who are immunocompromised, especially those who had solid organ transplant. And then there's no really reports of chronic infection in E1 and E2. The biggest patients that we're really concerned about are pregnant patients. They can have acute hepatic failure, and the mortality rate actually can go up to 25%, especially in the third trimester. Other things we worry about, those patients can have some neurological issues like Guillain-Barré. They can have kidney issues from hepatitis E. The treatment is kind of all over the place, but you want to, if they're on immunosuppression, you want to reduce the immunosuppression therapy, maybe give them pegylated IFNA, maybe riboflavin as well, have been shown to successfully treat some patients as well. All right, last but not least is Hep A. All right, Hep A is, again, a small virus. The route is fecal-oral. A lot of patients clear it pretty good. Your patients would have fever, nausea, abdominal pain, jaundice. There are about 1.5 million clinical cases reported worldwide, and it's like you can see there in the heat map where it's pretty prevalent. It kind of, when the patient have it, they have the incubation period, the ALT goes up and then it comes back down. There's also the idea of relapsing Hep A, where your patients have elevated ALT, they do better, and then they go back up. There's that relapsing Hep A, and the most common treatment is just kind of like supportive care. And this is just like two tables, kind of like what to do when you have a positive patients for Hep A, which patients kind of like treat, which patients you be concerned about, and which patient you just kind of like reassess. But again, the big thing is supportive care. Some patients, unfortunately, will just go on somehow and develop acute liver failure, and they will need to be transplanted. Some patients take a long time to recover, like maybe even greater than 3 months, and some will have the relapsing hepatitis will go up and down. Again, for prevention, and those were like big questions on like our exams, is like what to do if a patient comes to you and they're less than 40 years old and go into a place that have endemic to Hep A. You give those patients hepatitis A vaccinations. But if they're greater than 40, or they have some sort of a chronic liver or chronic immunosuppression, you want to give them hepatitis A vaccine and immunoglobulin. All right, so we talked a lot about chronic Hep B, acute and chronic, and we talked about the what to do with all the nuances to treatment and identifying kind of serologically what does Hep B mean. We talked about Hep C, E, and A. And that is a whirlwind of hepatitis. Any questions for me?